Our last speaker of the morning session is David Highfill, who is a licensed clinical social worker who started with our program back in April, and we feel very fortunate to have him become a member of our team. And the instigation for having a social worker came from the accreditation requirements, but we've known for a long time that this was a missing link, and he's become a critical part of keeping these patients both physically and mentally stable, and also helping us bridge into all access to care issues. So David is going to finish our morning session talking about focusing on quality of life, psychosocial obstacles, and setting realistic goals for lifelong care.
Good morning. I don't have any professional disclosures, but I do have a personal one. Like Dr. Reardon, I'm also a patient. I like to call myself a recovering congenital heart disease patient, as I was transplanted in 2012. So being that that's what it may be, that also means that I was expertly treated by the lovely Dr. Abelhosen here for a few years. And many of the other doctors in this room have also contributed directly to my care. Anyway, without further ado, quality of life. What exactly does quality of life mean? Well, I looked for a few definitions, and there are hundreds, and unfortunately in all the studies that I found, each one of them seems to have their own definition of this topic. But I stuck with three easy ones. Webster's defines it as simply how good or bad a person's life is. Believe it or not, in the University of Toronto, there is a quality of life research unit, which I think is amazing. They define this as the degree to which a person enjoys the important possibilities of his or her life. And the World Health Organization defines it as, get ready, one big breath, here we go. The individual's perceptions of their position in life in the context of the culture and value systems in which they live, and in relation to their goals, expectations, standards, and concerns. There we have it. So, as you can see, it's quite a variety there. In addition to that, there are several tools that have been used in studying congenital heart disease patients' quality of life. There is no single tool. As of 2014, there have been a total of 234 quality of life studies done, conducted in 35 different countries. The most common of the some 90 survey tools that were used in all those studies are listed below. Most of those studies, by the way, basically have kind of a list. It's a survey of somewhere between 26 to 36 questions, just asking patients various things about personal satisfaction with their physical or mental status, social accomplishments, health and physical qualities, etc. The World Health Organization comes into play again as they identify 6 specific domains within which quality of life is measured. This basically, they define these to be, as you can see, their physical, psychosocial, level of independence, person's social relationships, their feelings about their environment, where they live, and so forth, and religious beliefs or spirituality. Of course, some studies do not use these 6 domains. Some only use 4, some only use 3, and some of the domains vary between studies as well. Since I'm a social worker, I deal mostly with words, but I did find a chart so everybody can kind of relate to this presentation. Basically, this kind of shows the history of quality of life studies done. Beginning back in 1974 is when the first quality of life study was done. And basically from the early 1970s up into the mid-90s, only about 1 to 3 quality of life studies were done each year with congenital heart disease patients. Really, it's in the mid-90s when this field kind of took off and started to flourish. And as of 2014, it actually peaked that year with a total of 34 studies being done. In 2016, which isn't on this chart, it actually went down and there were 31 quality of life studies done that year. A man by the name of Philip Moons is a professor of nursing science and research coordinator in congenital cardiology at university hospitals in Belgium. He himself has been the lead author or part of 150 of these 234 studies. So let's talk about some obstacles in measuring quality of life. As you may expect, some studies have shown that CHD patients report overall having a poor sense of a quality of life than the general population or by other members of a same age group. A 2002 study in Birmingham, United Kingdom, with a sample size of 276 patients, resulted in a rather interesting finding that did show CHD patients indeed did score lower overall quality of life scores. What was interesting was that 3 groups in particular had the poorest scores in this study. Those deemed to have either inoperable or cyanotic conditions, and those who were determined to have been surgically cured. Now, I know a lot of you in this room are wondering what surgical curation looks like, as am I, and unfortunately they didn't exactly define it in that study, but they hypothesized that possibly that group did so badly or reported that their quality of life was so poor, even though they had technically been cured, possibly due to the patients no longer receiving ongoing care as they'd grown accustomed to throughout the CHD lifespan. You start with pediatrics, as Dr. Britton talked about earlier, and work through that transition process. If at some point they become cured, well, now they kind of lost their congenital heart disease family, so to speak. Also, they postulated that it could have something to do with the zipper scar that they carry around with them for the rest of their life, kind of referring back to the time when they definitely did have a major cardiac defect or something that kind of triggers that or reminds them of that. On the flip side of that, several studies have also shown where congenital heart disease patients score at least as well or even better than the general population in terms of their perception of quality of life. Interestingly, a 2011 study, CHD patients reported that their quality of life was higher in 3 out of 4 domains studied in that particular study, those being the psychosocial, social relationships, and environmental, as compared to same age members of the general population. The only area where CHD patients reported a lower score in this study was in the functional or physical capacity score. An international study done in 2016, using a total of 4,028 patients' responses over 15 different countries, patients in that study generally reported that their quality of life was very good. They didn't necessarily compare in this study, it was just a rating overall, and they averaged out on a scale of 100 to in the low 80s, which is surprisingly high. So how is it that some CHD patients, or a lot quite frankly, report that they actually have a very good quality of life? At least as good or sometimes better than people that do not have any such congenital ailments. Getting back to Philip Moons again, he postulates a disability paradox, wherein he says that maybe these people have become comfortable with themselves to the point that they are able to discuss their disability with others. They kind of understand what's happening and they're able to talk about it. He also said that they may feel a sense of control over their bodies, kind of understanding what their medications are for and being able to function in the normal world. They may also have developed a strong general sense of satisfaction when comparing themselves with others. And speaking as a former patient, sometimes, yes, you do look around the waiting room and say, oh, I'm doing better than that guy. Look, maybe I'm doing better than her. I'm definitely not running marathons like that guy is. But, you know, you do kind of compare yourself. Whoops. I don't know what happened. Okay. Some more obstacles. Again, there's no single survey tool used to study or in these studies that were done on aspects of quality of life with respect to the congenital heart disease population. This is very different than the role I used to do, which is in kidney dialysis, in that back in 2005, the Centers for Medicare and Medicaid Services mandated that social workers basically start using a survey tool called the KDQOL, or the Kidney Dialysis Quality of Life Survey. And that is specifically designed for dialysis patients, so that their quality of life is actually mandated that social workers assess that with the patient annually. And if they're struggling, more frequently, usually monthly or quarterly. Unfortunately, at this point in time, we don't have that for congenital heart disease. That's okay. So one factor that kind of stuck out in most of these studies was the value of the patient support system and their overall projection or assessment of their own quality of life. The value of this single issue has been shown across multiple studies, almost regardless of any other factor, whether it be their functionality, their level of symptoms, number of surgeries they'd had, etc. If the patient feels they have a strong support system, this appears to override many of the other issues in determining their perception of how they feel, and thus their overall quality of life. Now, in my experience, as Pam said, I've only been here since April of last year. But in my experience here, for the patients that have been referred to me for counseling services, this does in fact hold true. A lot of the patients that are coming to me seeking ongoing services, or those who need to be referred into the community for ongoing therapy, are really people struggling not just with their congenital heart disease, which actually seems to be a secondary factor to a lot of family issues going on at home. A lot of these people may come from broken homes. They may have other issues with regard to substance abuse, with regard to a history of physical or sexual trauma in their childhood, or marital dysfunction at home, any number of psychosocial things. If they do not have a strong support system, that appears to be a very detrimental factor. Basically, when I first started in this position, I kind of assumed that I would be seeing a lot of patients, or those who would be referred to me would be patients that were struggling with a lot of depression. Again, I was kind of balancing that due to poor functioning overall, really not thriving in school or in work or what have you. As it turns out, however, probably the most prominent symptom that I'm seeing in our CHD population here are patients experiencing anxiety, sometimes even up to panic sensations. Patients who may have had a syncopal episode in the past where now they're fearful that that might happen again, or a pacemaker failure, things like that. Even to the point where some patients have experienced legitimate panic attacks. Also, post-traumatic stress syndrome has also been another common symptom that I've seen among our patients that have been referred to me. Various triggers applied to this factor. It could have been something procedural or something totally unrelated to their heart disease that set them off. Possibly, though, it may be something secondary to that in that they had just received a cath or a procedure, a valve replacement or repair, and during their hospitalization, perhaps they contracted some sort of infection. So now they have a fear of hospitals, and this type of thing may take place. What I've kind of found, though, is throughout the life cycle for congenital heart disease patients, there's really a series of adjustments that take place. It's really not that they're necessarily clinically depressed, although yes, some are, or clinically suffering from anxiety disorder or panic syndrome or something like that. I've kind of termed this to be a chronic adjustment situation where patients, as they move through the life cycle, have to deal with different symptoms, new symptom onsets, a varying degree of symptoms, struggling possibly with controlling their medications, as Jennifer Doliner talked about, struggling with their insurance and maintaining this. So there's a lot of ongoing adjustments, not just in where do I go to school and what sort of work do I want to do, but even within that subcontext, they have to start thinking about how close to my doctor do I want to stay if I do go to college. That can be a very big factor. Also, what type of job? I need to make sure I get a job that has insurance. These types of things are really kind of following these patients throughout the life cycle. In addition, the need for stable insurance benefits that we talked about can delay life transitions for some patients as well. And again, as was discussed earlier, we really don't know what the future holds. We certainly hope that the pre-existing condition clause does not disappear. Common triggering issues associated with many of these symptoms appear to include their anticipation of events such as facing open heart surgery, or possibly even procedures that may including valve repair replacement, as I said, and even cardiac catheterization. I had one young lady who actually had only had one cardiac cath, and while she was talking about her memory of it at age, I think it was 9, burst into tears just right there in the exam room. She was really struggling with post-traumatic stress of thinking about having to repeat the catheterization. So really took a lot of counseling, kind of normalizing those situations for her and kind of walking her through that, reassuring her that it's a much more common procedure. Hopefully she wouldn't have the same side effects or negative experience that she did the first time. Some more obstacles. Here you see a list of what some of our patients have indicated are important values to them. Now, I kind of threw out the question of them because we don't necessarily have a specific tool to gauge quality of life. I thought, well, let me ask our patients here at UCLA. So within our support group structure that we have once a month, and also within some of the patients that I'm seeing individually, I started to ask them what they value to be important in terms of quality of life for them. Basically, a lot of patients say uncertainty of symptoms, that kind of affects how they feel about how they're doing, a decline in their function, as you may well imagine. Their level of independence, feeling like they don't have to rely on others, is a huge factor. And several males, and in the support group, when one male mentioned this topic, all the females in the group chimed in as well. But sexual performance and sexual functioning is also a great consideration for congenital heart disease patients, possibly due to the disease itself or possibly as a secondary cause of some of the medications that they're currently taking. So what are some of the goals for lifelong care? Part of providing psychosocial support includes providing psychoeducation to patients to assist them in navigating their treatment and understanding their treatment plans. This is part of what I try to do. I try to help patients to understand the importance of coming to all their appointments and making sure that if they can't make the appointment, they call and let the team know why and hopefully try to reschedule that. Adherence to their schedule is extremely important. I also try to encourage them to ask questions when they do meet with the doctors about their diagnosis. All the doctors that I've ever met here at UCLA have always taken the time to answer questions, draw diagrams and so forth to make sure that all patients understand what's happening to them. Also, understanding the need and the particulars about their medication regimen is very important. This is something I encourage people to do in support group. In addition to that, I also try to promote patients to be very proactive, and as Dr. Reardon talked about earlier, starting to take responsibility for their own health care. As you're getting older, moving into adolescence, some congenital heart disease patients actually seem to mature a bit more slowly, probably because their symptoms have been more severe and they've had to rely on their parents much more than somebody who didn't suffer from this type of thing. So getting them to become a little bit more proactively assertive and gain their independence takes a little more time. So I try to encourage them. You know, you're probably going to think of questions when you're not here sitting in the doctor's office or here in the support group or wherever you might be in clinic. So you take out your smartphone, use your note app or whatever you have, and write things down in that. Most people have a smartphone these days. For the older population like me that still uses paper, I encourage them just put something on your refrigerator and jot down your questions, whenever you're at home. That way, when you come in, Dr. Abelhoz and Dr. Child have always taken the time with me, and I know they do this across the board. When they say, do you have any questions for me? Well, yes, I do. Get out your list, and they will indeed take the time to go over that. So I do encourage patients to do this as well. Also, the availability of psychosocial support, not only within the adult congenital team, but also in the community, is very important as an adjunctive research support. Sorry. And I think I'm on 15 now. Let's see. Yeah. Okay, so working to provide effective psychosocial supports to patients. I'm going to try to move a little quicker through this. Try to focus on expanding the variety of psychosocial mental health needs and issues presented by patients throughout the lifestyle. Try to assist with short and long-term goal setting for our patients so that they can navigate some of these lifestyle changes and thoughts of going to school and moving on into their careers a little bit easier and kind of break it down into more manageable, more controllable tasks. Try to assist patients with normalizing their symptoms and concerns within the broad scope of congenital heart disease functioning. In other words, letting them know that the symptoms they're having are fairly common within other patients who've done that. Their fear of going into the cath lab, their fear of having a valve replaced is shared among all the patients who've had to deal with this. And again, in the support group that we're doing now, we're trying to bring some of these factors out and get those on the table so people can share their experiences. And it really is working wonders with kind of settling people down and making those peer connections over time. Also trying to utilize internal and external psychosocial supports so they know when they can contact me for extra support if they need it, even if they're not in the hospital or in clinic. And also trying to coordinate with them so they can find good therapists in their communities. I also try to provide education to risks and benefits of online information and support. Now, we've had some patients who've actually been very traumatized by what they found online. And as you can imagine, with social media and all of the outlets that we have today on the internet, it's very fantastic. Unfortunately, it's not always accurate, and it can serve very much to actually scare a person rather than support them and get them the proper information. So what we also try to do is guide them to some sites that might be more effective and might serve them better. So in summary, basically, I'm going to have to turn around because this monitor is broken, pardon my neck. There have been 234 studies employing 90 different surveys across 35 countries as of 2014, and right now that's actually at about 300 studies overall. As yet, there's no single adult congenital or congenital heart disease quality of life survey tool that's being used. There are, in fact, multiple psychosocial obstacles for congenital heart disease patients in achieving and sustaining a positive quality of life and setting their goals for care throughout the lifespan. The value of the patient support system, I think, was highlighted here, in that if they do come from a strong background or they have a strong marriage, a strong parenting system, what have you, it really helps them manage all of the issues related to congenital heart disease much easier. The role of the congenital heart disease social worker, certainly I'm happy to be one, and I'm very happy that we're continuing to move in this direction to make it more of an interdisciplinary team approach, and integrating mental health issues into the congenital heart disease patients' overall care throughout their lifespan, as I've kind of focused on as well. So thank you very much. I really appreciate your time, and enjoy your lunch.